afternoon, good morning, or good evening, depending on where in the world you are. I would like, on behalf of the SOE, invite you to join our webinar on pediatric ophthalmology. Before we begin, I want to run through some quick housekeeping items. The audience questions you can ask through question and answering Q&A, and we will be looking at them and trying to answer as many audience questions as possible. If you have a particular question after the webinar that was not answered, please email it to soewebinar@soevision.org, and we will try to answer them in a separate document which will be accessible through the SOE website. The webinar is being recorded today and will be available at later at the SOE website and placed on the SOE YouTube channel. I would also like to talk you through the running of order of today. There will be 5 presentations consecutively. Then there will be followed by a final discussion with all speakers at the end of the session, except Chris Lloyd, who has the last presentation. He cannot join us for a webinar because he is a visiting professor in Canada at this time, where he has to give a presentation as well. The webinar will have 5 presenters on LHON treatment in children, ROP update, topical treatment for infantile hemangioma, pediatric cataract surgery, the challenges and recommendations for 2022, and the pediatric cataract, the role of genetics. And we will start with the first presentation. That will be Dr. Claudia Pringler from Munich, and she will talk about LHON treatment in children. And she's a pediatric ophthalmologist and neuro-ophthalmologist from Munich joining us, and we love to hear her talk.
So a warm welcome from Munich to my presentation on treatment of LHON in childhood, and I would like to thank the SOE for inviting me to share our experience on this issue. These are my financial disclosures. Before we talk about LHON in children, I think it's necessary to share some data on what we know about adult onset LHON. So typically LHON is perceived as a disease of young men because the typical age of onset is between the 2nd and the 3rd decade, and 80% of the patients are male. LHON in 90% of the cases is caused by point mutations in the mitochondrial genome, with 70% being due to the mutation 11778, which is the most severe one and causes the most severe course of the disease, and the mildest course we have with the 14844 mutation. When LHON starts at an age of younger than 12 years, it's defined as childhood onset LHON. And this was not known to exist until Barboni in 2006 described his first case series of 14 patients. And altogether, we have now only about 137 cases described in literature. From these data, we know that the LHON in childhood is an atypical LHON, not only in terms of the age of onset, also because male preponderance is not as pronounced. So we have to keep in mind that girls can be affected by LHON as well. Also, the clinical course appears to be different. From adults, we know that they experience a subacute unilateral vision loss, which is painless, and vision declines rapidly within half a year to 1/50 or even less, and then reaches a plateau for the rest of their life. And in children, there are slowly progressive and insidious courses as well. So this has to be kept in mind when dealing with children with childhood onset Leber's hereditary optic neuropathy. Also, unilateral courses are possible, but the good thing is that the children have a better visual prognosis overall. So adults reach a mean visual acuity of 1/50, and the children at least of 0.2. Another good thing about LON is, at least for the adults, that we have a treatment. So in 2015, the EMA approved idebenone for treatment of LON. And benefit was proven for carriers of the 11778 and the 3460 mutation. It's recommended to begin the treatment within the first year after onset. For children, however, this is an off-label treatment, and before we decide to do such a treatment in children, we want to know two things. First of all, does it harm the children? And second is, do they benefit at all? If we look at idebenone treatment in adults, what can we expect? So the mean best corrected visual acuity in the natural course is about 1/50 or even less after 52 months. So they are all off charts. After treatment with idebenone, 50% of the patients were reported to respond to the treatment. So how was response defined? Response was defined as a gain of more than 2 lines after 24 to 30 months of treatment. The mean gain of visual acuity in total was about 19 letters, which equals to 4 lines. Better recovery was observed when the vision did not decline too deep. And finally, about 56% of the eyes in the natural course and only 30% of the eyes after idebenone treatment remained below 1/50. So to answer the question, what should we do with children? Should we or can we treat them with idebenone? We went into the MitoNet registry, which is Germany's biggest database on retinal diseases, and found 61 patients with an onset at a very young age. We subdivided them into 2 subgroups. One subgroup was the typical childhood onset LON with an onset at an age of younger than 12 years. And the second subgroup was also with an earlier age at onset. They were only 12 to 16 years old when the disease became manifest. And both were subdivided in a natural course group and in an idebenone treated cohort. Looking at the demographics, you can see on the left-hand side the childhood onset cohort, and on the right-hand side the early onset, the teenagers. And it's very obvious that in the childhood group, we have about 1/3 of children that were girls. So please always keep in mind that girls can be affected, and 80% have an insidious or slowly progressive, so that's an atypical mode of onset. Whereas in the teenage group, and this is also remarkable, almost all affected were male. The distribution of the LON mutation was just like in adults, and another peculiar finding was that in both age groups, we didn't have a single patient with the most benign mutation in natural course. Probably, or maybe because the prognosis in the long term is so good, they didn't even enter the registry. To answer the first question, can we treat? So we found that idebenone was very well tolerated. Treatment didn't have to be interrupted in a single patient because of side effects. Second question, should we treat? So there are many measures that can be taken. We decided to determine mean final best corrected visual acuity and 2 parameters of practical relevance, of functional relevance. That was the proportion of severely impaired patients and the proportion of those with a very good visual acuity. So if we look at the natural course, the teenagers, interestingly, were almost as bad in the long term as the adults. They did slightly better, which about 2 lines, but still very bad. The children, however, as reported in literature before, were about 7 lines better than the at onset patients. So the visual prognosis, if you look at the different LON mutations, also like in the adults, was critically dependent on the underlying LON mutation, with the 11778 mutation having the most severe course. After treatment with idebenone in our group, none of the teenagers overall had a benefit from the treatment. So they were still as bad as in a natural course. However, and that was interesting, the children improved in their mean visual acuity, especially in the third year of treatment. Looking at the proportion of eyes with a very bad visual acuity, which is important in patient counseling because they always want to know whether the child will be legally blind or dependent on low vision aids. We could see that the teenagers in long-term natural course did a bit better than the adults, with only 70% of the patients remaining beyond that level, and only 30 to 45% of the children in the long-term natural course in the most abundant mutation. When treated with idebenone, again, the teenagers did not benefit in this matter. However, and that was interesting, none of our children was still beyond 0.1 decimal after 36 months of idebenone treatment, but of note, it's only a very few cases reported here. Looking at the proportion of eyes with a really good visual acuity, that means independence of low vision aid or even being able to drive a car, 11% of the eyes in young teenagers reach this point in the long-term natural course, and 20 to 30% of the children. After idebenone treatment, again, we couldn't see an improvement in the teenagers, but again, we found an improvement in the children after 36 months, that's 3 years of idebenone treatment, with 50% of the eyes being better than 0.5 decimal in the most malignant LON mutation. The interesting finding also was that the clinically relevant recovery, that's the main measure often taken in clinical studies, defined as again then more than 2 lines from nadir, was comparable in all age groups. And this was irrespective whether we take a milestone of 2 lines or 3 lines as a measure. So the rate of clinically relevant recovery is comparable, and it's also comparable to that was found in adults after Rexone treatment, where they reported 50% after 30 months of treatment. However, the children do much better than the adults. So how can that be? And this becomes clear if you looked at the trajectories of best-corrected visual acuity in the long term. The children here in orange, because it's logmar visual acuity, it's above. The children are in blue because it's logmar, they are at the lower level. In the whole course of the disease, don't lose as much visual acuity as the teenagers do. So they experience a much milder course of the disease. And the impact of that becomes clear if we look at the range of logmar visual acuity. So there are certain milestones available, like hand motion visual acuity, counting fingers, 1/50 off chart, or legal blindness, and the independence of vision aid. And that's not the whole end of the spectrum. And if we put the course visual acuity of our children and our teenagers into that scale, we can see that the teenagers are ranging in the very, very low visual acuity group. So if somebody with a visual acuity of logmar 2.3 improves about 4 lines, he's still only at counting fingers, which is defined as 1.9. So this might still be an improvement, but it's just not of real functional relevance in our world. Taken together, we made the observation that if LON begins at a very young age, there are maybe 2 different groups of the disease. So childhood onset on LON appears almost to be a known entity with a very benign course of disease. 1/3 are girls, an incident slowly progressive course of disease. And often they have a family history that's positive, especially in our girls. Often the mother was affected as a child. The early teenage onset group, where the patients are not much older when disease begins, are in 90% of the cases male, often also have a positive family history, and they appear to experience a particularly severe course of the disease. So taken together in our small patient cohort, children had a benefit from idebenone treatment in all aspects. The teens, however, not as far as the visual acuity measures that we took are concerned, but they still gained more lines, more often, more than 2 lines than if they are not treated. So taken together, as far as our data can be interpreted, Iodine treatment may positively influence improvement vision, especially after childhood onset to levels of functional relevance. The clinical recovery, however, the rate was comparable in both age groups, and the extent of vision loss at nadir, therefore, significantly determines the final outcome, may be important for patient counseling and the prognosis of the patients. The major challenge, however, for us ophthalmologists in the first line is to establish the right diagnosis. And I think that LON should be added to the differential diagnosis of a medically unexplained vision loss in children, because young children can develop coping strategies. They have slowly and insidious causes of the diseases, so they may adapt to the vision loss very easily, especially if they have unilateral causes. And please always keep in mind that girls can be affected as well. So I want to thank you for your attention and thank all the colleagues from my department who helped collecting this data. And at the same time, I'd like to invite you to the EPOS, which will be held in Munich in this fall. Thank you.
Thank you very much, Claudia. That was excellent. I will have an opportunity to discuss all presentations at the end of the webinar. I would now like to welcome our second speaker, Anne Helmström, who will discuss ROP and update. Professor Anne Helmström is a pioneering researcher in the field of ROP, who has developed innovative and reliable tools to optimize the prediction of infants at risk, demonstrating important mechanisms of pathogenesis, discovering new innovative therapies to prevent ROP, and evaluating these in clinical trials. It gives me great pleasure to introduce Professor Helmström next.
Dear colleagues, thank you so much for inviting me to give this talk regarding ROP and update. So this is what we do when we have our clinic. We screen preterm infants. In most countries, we have national guidelines for ROP screening. And in Sweden, we screen all infants born below 30 weeks of gestational age. And in approximately 25% of the infants, this is what we see. We see an abnormal retinal growth, but in 75%, we see completely normal retinal vessels. In another, approximately 6% of the children screened in Sweden, they need treatment. And this is a baby treated for very severe aggressive ROP. And ROP is still one of the main causes for childhood blindness in the world. So thanks to our patient registry that we have on all children screened for ROP in Sweden since 2007, we have now almost 12,000 babies. And due to that, we have been able to draw the ROP natural history. And as I said, approximately 75% of the children will never develop any ROP, where 25% of the babies will develop some stage of ROP, and approximately 6 to 7% of the babies will be treated. So what we have seen in Sweden, and so is true for other countries, is that we have seen an increase of the most immature babies born, and that hence need screening. And these are the babies born in weeks 22 and 23 in Sweden from 2007 till 18. And as you can see, we have had a 50% increase of babies surviving these very immature gestational ages. And of course, this survival results in that more infants will develop more severe disease, since gestational age is still the strongest risk factor for severe disease. So we have seen an increase in Sweden of the babies treated for ROP. And this is also true for other countries with neonatal care of a certain degree. So more babies need treatment. Thus, more babies will be in the risk of severe visual impairment. I think it's really important to remember that ROP is not only a vascular disease, it is a neurovascular disease. And it is actually the astrocyte precursors that are the main source for VEGF production right here at the border between vascularized and unvascularized retina. A couple of years ago, there was an experimental study where the possibility of the astrocytes in the brain were knocked out for their capability of producing VEGF. So loss of VEGF resulted actually in hypovascularization and hypoplasia of the cortex. And the authors concluded that embryonic glia cells serve as a source for VEGF to promote cerebral angiogenesis in a manner that can be compared to the retinal astrocytes. And it is well known that ROP is one of the stronger biomarkers for later cognitive and developmental outcome in preterm babies. We were interested in looking at a brain injury biomarker, the neurofilament factor light. And what we found was that it was quite dramatically increased in the babies that had any sign of ROP compared to the babies that had no sign of ROP. And the reference value for adults regarding brain injury is here around 20. And as you can see, a majority of the preterm babies have levels that correspond to brain injury levels for up to a month. And the younger the babies were, the higher the levels. And also we found that it was related to ROP. And this was true even when we adjusted for gestational age. So it seems as what happens in the retina also happens in the brain when there is abnormal neurovascular development. Recently, we looked at the most immature babies and the diagnosis of these infants. And we found in Sweden over a 12-year period in 399 babies that were born below 24 weeks of gestation, that 22% of these babies or children were visually impaired, and that all of the visually impaired children also had other neurodevelopmental disorders. And of these babies, 64% were treated or had been treated for ROP. But there is about a third of the children that have other causes than primary retinal causes for their visual impairment. So what risk factors are there for this disease? Well, oxygen, of course, is a well-known risk factor, and it's more and more realized that it is the variability in oxygen delivery that is the strongest risk factor. Blood components like low fetal hemoglobin, for instance. It has been shown that in babies that rapidly decrease their fetal hemoglobin levels, that they are at higher risk of severe ROP compared to if they have a bit slower decrease. The reason for this decrease is primary iatrogenic phlebotomy. We take a lot of samples in these babies to follow their clinical course, and we transfuse the babies with adult red erythrocytes. But by doing that, we also change the oxygen delivery to the babies. Another blood component that has shown to be connected to ROP is the platelets, and especially in the second phase of ROP, low platelets is for sure a risk factor for this disease. Hyperglycemia or deranged metabolism has also been associated with ROP, as has prolonged parenteral nutrition. Inflammation, infection is also a risk, especially during the second phase of ROP. So what about treatment? Laser is still the standard in our country, but in many countries, most of you know that anti-VEGF is is becoming more and more popular as a treatment. We know that with laser that the children are at high risk of developing myopia. We know that it is dependent on the treatment doctor. And we also know, thanks to fundus photography being performed after laser, that it is the skip lesions that is the cause in most cases of recurrence after laser. So we strongly advise to perform a photograph of the retina after the laser session, so that extra laser spots can be put if a skip lesion is found. Anti-VEGF. We know that the risk of recurrence is higher when we give anti-VEGF. We don't really know exactly when the recurrence will happen, so these babies have to be followed thoroughly for a long time. And it is still being discussed regarding long-term systemic effects and the optimal dose. When it comes to prevention of ROP, there was a publication a year ago where fatty acids were given enterally from birth to 40 weeks of gestation as a compound of omega-6 and omega-3. And in that study, there was a reduction of 50% of severe ROP. And this is really striking results. And we will see how a nutrition regime will adapt to this finding, if it will adapt, and where then this can be one way of reducing the most severe forms of ROP. Other treatments that are being investigated for prevention is the use of the beta blocker propranolol. There are also studies ongoing where the aim is to reduce loss of fetal blood components, and also studies that will aim at, instead of giving adult erythrocytes, give cord blood erythrocytes that contain a much higher fraction of fetal hemoglobin. But there are also studies ongoing looking at possibilities of reducing inflammation in the second phase of ROP. Now, as you might remember, we do screen babies below 30 weeks of gestation in Sweden, and still approximately 75% of the screened babies will never develop any ROP. There are and have been developed prediction models to try to identify babies at risk, so we could reduce screening at those that have no risk of developing severe disease. And this is an algorithm developed by Aldina Pivodic using data from our SWEDRUP registry. And it is freely available at this internet site. And all you have to do is to enter the gestational age of the baby, the birth weight, and the sex of the baby, and then press calculate. And as in this case, this 27-weeker had a very, very low risk of developing severe ROP. And the blue dots here are babies in our register that never developed ROP. The red dots are babies that have developed ROP. And as you can see, this baby is considered to be out of risk and could be released from screening. This baby, however, a little bit younger, with a birth weight of 900 grams, also a girl. This girl has a higher risk, a 5.39 individual risk of needing treatment for ROP. So this baby is advised to still screen. And this is only using birth data or data available at birth. And by doing that, we could reduce 50% of the babies from screening. It can also be used to reduce, maybe to skip or reduce the baby from screening a little bit earlier. If you have a baby that has not developed any ROP, and then if the baby gives no sign of needing or being at high risk of needing treatment, the baby can be released earlier from screening. This algorithm has now been developed further. So while screening, you could put in your screening data. You put in the birth date of the baby, the date for prediction, and if the baby has the ROP or not. And then you will get another advice whether the baby should be continue to be screened in this case. And this is done in week 9 postnatal age of the baby. A couple of weeks later, 3 weeks later, we do the test again. And then the baby is considered at no risk of needing treatment anymore. And this is approximately 1 or 2 weeks before the baby is 40 weeks old. And then the baby could be safely released from screening. So by doing this, another 25% of the babies can be released. So all of this, these prediction models aim to identify high-risk babies and to be able to release low-risk babies from unnecessary screening sessions. So by this, thank you so much for listening, and I'll be happy to answer any questions from you. Thank you.
Thank you, Anne, for this nice presentation. We will collect answers at the end of the webinar, and then we will all discuss them together. And so thank you very much. We received a couple of questions, but we will answer them later on. I would now like to welcome the next speaker, my co-moderator, Darius Hildebrand, who will discuss topical beta blockers for infantile hemangioma, a 10-year experience. Darius is a dear friend and colleague from the United Kingdom, and he is also the present president of the European Paediatric Ophthalmology Society, who is co-hosting this webinar. Please, Darius, start your presentation.
Good afternoon. My name is Darius Hildebrand. I'm going to speak on topical beta blockers for infantile hemangiomas and our experience with it. Infantile hemangiomas play a large role in pediatric ophthalmology. They're the most common pediatric lid and orbital tumors and most common tumors in infancy. The incidence is 1 in 25 to 50 infants, 64% involve the face and 7% eyelids or orbits. Following a rapid proliferative phase for the first several months up to a year, there's a variable plateau phase followed by slow involutional change at a rate of about 30 to at a rate of about 10% per year. Ophthalmic indications for interventions earlier are development of or risk of amblyopia, mechanical strabismus or proptosis, compressive optic neuropathy, or facial disfigurement. The mainstay treatment until 2008 was corticosteroids, systemic or intralesional. But corticosteroids are frequently associated with side effects, some of which are can be very severe, as listed here. A change happened in 2008 when a French team around Dr. Léoté Labrèze made a fortuitous and serendipitous discovery of the therapeutic effect of oral beta blockers in infants with infantile hemangioma who had coincidentally been treated with propranolol for cardiomyopathy. And since then, beta blockers have become first-line treatment for infantile hemangiomas. The problem with oral propranolol is that, again, you have systemic administration and therefore systemic side effects, including hypertension, heart failure, bronchospasm, respiratory failure, and metabolic changes. In the largest prospective cohort so far, 906 consecutive French children on propranolol with a median dose of 2.0 milligram per kilogram per day for 190 days, and with more than a year of follow-up. 8.8%, or 1 in 11 children, had adverse reactions. 1 in 38 had serious adverse drug reactions, defined by the authors as any ADR leading to death, life-threatening injury, hospitalization, disability, or permanent damage, or any other important medical events as judged by the investigator. Children on oral propranolol clearly need close monitoring, therefore. There's also concern about these developing infants that there may be long-term risk of systemic beta blockade, to which we'll come back in a moment. Because infantile hemangiomas are essentially a cutaneous disorder, a transcutaneous topical application of a beta blocker is inherently attractive an option. So what is the evidence this works? In superficial infantile hemangiomas, we reviewed the literature several years ago, and we noticed that very few side effects are indeed reported with transcutaneous topical administration. There have been multiple studies since, including this large US multi-center retrospective cohort study of 731 children that reported a remarkably low rate of bronchospasm, only 0.4% in these infants, no cardiovascular adverse reactions, and no adverse reaction requiring timolol discontinuation. In 2020, two meta-analyses were published comparing topical versus systemic beta blockers. The first one is 1,235 patients, and it found that topical beta blockers were as effective as oral propranolol in superficial IH, but with few adverse effects. And the authors recommended that topical beta blockers replace oral propranolol as first-line therapy for superficial IH. That same year, a second, even larger meta-analysis was published of 2,098 children. And again, the authors found that topical beta blockers were as effective as oral propranolol, but with few adverse effects. And again, the authors recommended topical beta blockers, especially timolol, to replace oral propranolol as first-line treatment for superficial IH. This shows the similar effectiveness of topical versus oral, and this shows the superior safety profile of topical versus oral. So for superficial infantile hemangioma, topical beta blockers are now recommended first-line treatment because they're as effective and they're safer. But what about topical timolol for deep periocular infantile hemangioma? I've been treating hemangiomas with timolol drops for 10 years now, and several years ago, we collected a series of children with deep periocular infantile hemangiomas who had or were about to develop amblyopia due to strabismic reasons, mechanical restriction, due to pupil obstructing ptosis, or due to astigmatic or anisometropic reasons. This is one such child, a large hemangioma on the left side covering the left pupil. It has already developed amblyopia. We need to do something. And this is the treatment outcome with drops alone after 10 months, very good cosmesis, and with equalized vision now of 6/6 in each eye. This shows with greater temporal resolution what happened. So it presented on the top left slide here untreated. They came back a week later. It had clearly progressed. You can see the aggressive blood vessel circulation here, and it was occluded in the visual axis. The next slide shows the rapid progress following treatment with topical timolol. After 1 week, the visual axis is open already, 3 weeks, 5 weeks, and 9 weeks. There's another child, 18-week-old boy with bilateral mechanical ptosis, right pupil obstruction, and this child also had restricted up gaze, couldn't look up very well. Even after 2 weeks treatment, there was marked improvement. The final outcome was full extraocular movements, no more amblyopia, and normal cosmesis, as can be seen in slide C, and no recurrence following cessation of treatment. This shows, again, the same child with further shots taken at 2 weeks, showing the rapid recovery 6 weeks and 4 months. Okay, so what about then topical timolol for orbital infantile hemangioma? Now, this is a 6-week-old baby that presented to me with left severe proptosis. The parents did not want to have systemic beta blocker treatment, and so we tried timolol. And this is the same child, 3 months on timolol, a remarkable outcome. This is after 12 months and then having been off treatment for 1 year and no recurrence has happened. This is an excellent cosmetic outcome and an excellent functional outcome. The parents are very pleased. The resolution is confirmed radiologically after 1 year on the series of imaging before and after. And as you can see, the extensive lesion involving both the intraocular and extraocular compartments has resolved on the imaging. This is a 6-week-old baby with left proptosis and marked infradisplacement before treatment. And this is again after 4 months, a remarkable improvement for this degree of pathology. And after 10 months of timolol, very nice, very pleasing outcome physiologically and cosmetically. This is the same boy before and after 4 months in down gaze. This was an 18-week-old child with 5 mm proptosis before treatment at the top. And even after 9 days, one can see already how the proptosis is regressing because the retraction, the pseudo-retraction of the inferior lid on the left side has already given away because the eye is not pushed out so much anymore. One can also see the periorbital swelling in the upper lid, for example, here with fold billing, meaning that the congestion has started to come down. And this again, the same child before and as early as 9 days after treatment, showing remarkable improvement. So how do topical beta blockers work? The skin barrier function in infants is immature. The malleate in the timolol malleate is a lipophilic moiety that allows the molecule to enter the cross membranes, enhancing transdermal absorption. Once the timolol reaches the hemangioma, it is within a vascular compartment, which allows then vascular redistribution within the lesion. Timolol, pharmacologically speaking, is 10 times more potent than propranolol, and at the doses we use, it is equipotent to the dose of propranolol that is given by mouth. Another important aspect is that the renin-angiotensin axis in infancy is upregulated. As you can see here, the renin level is 14 times higher at birth than it is at 1 year. And beta blockers suppress this axis, which then leads to reduced VEGF production and increased apoptosis. One concern we have with this, of course, is that this is a physiological process, and blocking this, could it cause other long-term problems with systemic administration? We reported the first histology and electron microscopy of timolol-only treated children. And what we found is early evidence of apoptosis as early as 1 week following treatment, as can be seen on this toluidine blue stained section with nuclear fragmentation, or this pyknotic nucleus due to apoptosis. These are the late effects of timolol treatment. On the right side, this is a spontaneously regressed capillary hemangioma. It shows non-organized, chaotic deposition of collagen fibers, very few or no cellular remnants. Compare this to the timolol-treated tissues, where there are multiple onion skin-like concentric depositions, waves of depositions of collagen 4. In addition, it is much more cellular with surviving parasites, in fact. So what we think is happening is that the vasoconstriction causes acute hypoxia in the treated infantile hemangioma early on, which leads to smooth muscle and endothelial cell damage loss, but relative preservation of parasites, and then to concentric waves of collagen 4 deposition. We have seen evidence of apoptosis as early as 1 week following topical timolol treatment. So finally, how the drops applied? These are normal timolol 0.5 malleate drops from the glaucoma clinic, but the drops must not be applied directly to the face of the child, and this is because Some of the drops may percolate into one of the nostrils or into the mouth, have systemic absorption, and cause systemic side effects, which we don't want. So we apply the drops separately on a clean surface, 3 drops, 2 to 3 times daily. We dip a finger into the solution and then paint the wet finger, use the wet finger to paint the timolol into the skin overlying the hemangioma in the periocular area where it is, thus making it impossible to get the drop into the eye or into the mouth. It is much easier to do this in a sleeping baby, and fortunately babies sleep a lot at this age. So in summary, beta blockers have transformed the management of infantile hemangiomas. Systemic treatment with propranolol is effective, but can be associated with potentially serious systemic side effects. It is advised to tell the parents to discontinue propranolol during episodes of fasting, restricted oral intake, and respiratory disease for that reason. We have now over 2,000 reported cases of topical timolol since 2010. We know from several large meta-analyses that topical treatment is equally effective for superficial lesions and is in fact safer than oral systemic beta blockade. We don't know whether systemic beta blockade is more efficacious in deeper or orbital lesions to justify the greater risk. We show that even these deeper and orbital infantile hemangiomas can respond to timolol drop alone. We clearly need a multi-center RCT now to compare directly the effectiveness of topical and oral beta blockers for deep periocular and orbital disease. And in the meantime, topical timolol is a reasonable option, especially in infants with contraindications such as asthma or cardiac reasons, or where the parents object to the use of oral propranolol. Finally, I would like to use this opportunity to invite you all to our next 47th annual meeting of the European Paediatric Ophthalmological Society in Munich. One of my co-speakers this afternoon, I'm delighted to say, is Claudia Bricklinger, and she and her colleagues are organizing this event this year in Munich. And I look very much forward to seeing you there. I thank you and the organizers, and I look forward to any questions you may have. Thank you very much. I would now like to welcome our next speaker, Ed Wilson. Dr. Wilson is currently a tenured professor of ophthalmology and pediatrics at the MUSC Storm Eye Institute. He is the author, of course, of a encyclopedic textbook on pediatric cataract surgery, which is a real treasure box. It contains a lot of wisdom, a lot of information, and he has served in many functions, including president of our sister society, the American Association for Pediatric Ophthalmology and Strabismus. With no further ado, it gives me great pleasure to introduce Ed Wilson. He will speak on pediatric cataract surgery challenges and recommendations for 2022.
Welcome. My name is Ed Wilson. I want to thank the SOE and Dr. DeFaber for inviting me to participate in this session. My topic is pediatric cataract surgery, challenges and recommendations for 2022. Now, one challenge we have is operating on young infants, and there has been many publications indicating that the outcomes, at least the reoperation outcomes, are worse if an implant is placed in the first 6 to 7 months of age. And I think that most of us now leave these children aphakic. This presents some challenges, of course. Now, this is the way I tend to do the surgery. I like bimanual surgery. This is a 5-week-old. You can see the palpebral fissure is small, hard to get the lid speculum in there. I use a 25 gauge vitrector and an irrigating cannula through 2 paracentesis openings. I do a vitrector cut anterior capsulotomy. I aspirate the lens. I do a vitrector cut posterior capsulectomy, and then an anterior vitrectomy without ever having to leave the eye. So the nice thing, it's 1 time in, 1 time out, very fast, less inflammation when there's not multiple entries. I do use a tenovicral suture to close the wounds. And for me, I place the contact lens at the end of the surgery. You may or may not have that option, but for me, I have calculated, here's this child 1 day post-op. So I have already calculated the power of the power of contact lens that I need. We developed a specific A constant for the Silsoft contact lens, and we use that with our biometry just as though it were an implant. Now, another reason to leave these children aphakic, this is a graph showing mean and median reduction in contact lens power early in life. It's really a moving target. There's a lot of changes that occur in the power of the contact lens. The Silsoft contact lens is now back on the market in the United States. The FDA in the US approved the new packaging, and so we're about to be again fully stocked with Silsoft. I'm not sure that has worked out in Europe, and you may be struggling to find a different contact lens or even a daily wear option. And don't forget about aphakic glasses. Aphakic glasses work great. And at least in the bilateral cases, that's one way to bide some time until the child is old enough and the growth slows down, and then you may want to put in a secondary intraocular lens. Now, there are cases, again, some families really are challenged by the use of a contact lens. And in unilateral cases, you really can't use aphakic spectacles. One option I would like you to consider is using a 3-piece intraocular lens, placing the lens haptics in the sulcus, and then doing a bicapsular capture. This is easier to do in an infant and also easier to exchange compared to in the bag with posterior optic capture. So what I've done here, this is a fairly calcific capsule, but this family would not do well with contact lenses. And so I placed this lens in the sulcus, and now I'm struggling a little bit, but I'm going to capture this optic. Now that allows the capsular bag to seal so that you don't get that high rate of visual axis opacification from new cortex reproliferation. Now, I use this example just because it shows you that the bag is very resilient. There, even with struggling, I've gotten a good bicapsular capture in this instance. Now, because we are leaving a lot of these young babies aphakic these days, there are more secondary intraocular lenses needed as the children get older. My peak time is around age 4, 5, 6, but not every child needs a secondary implant, but many are ready to stop with the glasses or the contacts. Most of my secondary implants these days are in the capsular bag. What you've seen me do here is open the Sommering ring using an MVR blade. And now I'm taking the 25 gauge vitrector and turn the cutting port on its side, and I am walking my way all the way around 360 degrees to reopen the capsular bag and create a new anterior capsule opening. If the first surgery has been done correctly with matching anterior and posterior capsule openings, then the Sommering ring that is created, and that's age dependent, you get more Sommering ring the younger the patient was at surgery, that new material keeps the bag open. It holds that space. Once you open the Sommering ring, you really are obligated to remove all that material, clean it out, take the time to clean it out. All the time I'm visualizing my new anterior capsule opening. But this allows me to use a single piece lens, a lens that I would only place in the capsular bag. Now I'm putting ophthalmic viscosurgical device within the reopened capsular bag. And I think here in a moment, you'll be able to visualize that there is a new anterior capsule opening. I think you can see it. I can see it all the way around. I know that I've created space with the OVD. If the white ring, which represents the posterior capsule, it was where the capsule's fused. If that white ring is near the visual axis, you may want to remove it. But I would urge you to not remove it until after the lens is safely in place in the capsular bag. When you're removing the OVD and you go under the optic, then you can trim that white ring if necessary. I don't think I trimmed it in this case because it is really outside of the visual axis and it's not going to be seen unless the pupil is dilated. So here I was able to use a single piece lens that's really only appropriate for in the bag. And with this child, that lens is going to need to stay in for decades. So I feel better that it is now in the capsular bag. I will again sew the wound with Tenno Vicryl. I like Vicryl because I don't have to go and remove it later. Hopefully you have access to Tenno Vicryl. If not, you use nylon and then you have to go back. And so here I've removed OVD from anterior to the optic, but also from posterior to the optic. I rotate the lens so I don't run into a haptic when I do that maneuver right there. Now here's my typical case of a child who's old enough, this is a 2-year-old, to receive a primary intraocular lens. I use a manual capsulorhexis with a small incision capsulorhexis forceps. I use bimanual irrigation and aspiration, put the lens in the bag with the posterior capsule intact, take out all the OVD, and then I go pars plana to remove the posterior capsule. Now, doesn't mean that you can't do it anterior. Of course you can, and there are many ways to get this job done. What I found is that I have much more control this way. All the OVD is gone. I was taught that if you're going to cut vitreous, do your best to cut it where it lives. I go through using an MVR. I use a 25 gauge MVR. I was also taught that a trocar is used for tool transfer. And if you're only going to go in once, it makes more sense just to use an MVR, and then I close it. I know it may not need to be closed, but I close it with a Vicryl suture anyway. Now, we remove a lot of posterior capsules in children because of the rate of PCO is so high. That's another challenge. It's an old challenge, but it's one that we continue to deal with. You can see cellular reproliferation that has stopped at the posterior capsule edge here. I find that I'm doing more posterior capsule removals rather than less as the kids get older. YAG laser in children can be easy or hard. And if you're going to do a YAG laser in the office, I would tell you to do it early. Do it as soon as PCO starts, because as shown in this upper left picture, quickly the PCO gets so thick that the laser won't go through it. And in cases like this, we end up having to go back to the operating room and do it through the pars plana. Now, here's another thing we deal with. This is a successful YAG laser, but you have all this material because the vitreous is formed, all this capsular material and reproliferation material. Even when you've freed up the visual axis, in this case, I still had to go back through the pars plana to clean all this debris up, that you wouldn't see in an adult. So that leads me to do more posterior capsule removal rather than less. Another challenge we deal with is in ectopia lentis, the ones that progress rapidly in childhood tend not to be the ones that are very good for capsule sparing types of maneuvers. They're certainly okay to use in selected cases, but we struggle with these very rapidly progressing subluxation where it makes more sense to remove the capsular bag. Now, for me, my best option is to use the Artisan aphakia intraocular lens. We have a more limited access to these than you do in Europe. We have to do it through a compassionate use clinical trial protocol, but I now have done 93 of these. I have a few more coming up. I have enjoyed having access to this lens. I know you've had access to it for a much longer period of time than me, but many of our cases now have 5 years or more follow-up, and they're doing quite well. We are not allowed by the FDA protocol to incubate the lens on the posterior side of the iris, so I can't speak to that. I know that's popular. Just the way the protocol was written, we can only attach it on the anterior surface. We have to follow the protocol or we don't get access to the lens. Now, there is beginning to be more literature on using the flanged intrascleral fixation, the so-called Yamane technique, first introduced by Yamane at the ASCRS meeting several years ago with the winning the grand prize video. And so more and more people, I'm beginning to trust that this can be used in children. I use it now for children who do not qualify for the Artisan, mostly because they either don't have good iris or I can't prove that they have a qualifying 3.2 millimeter anterior chamber depth. This is one that really had no iris. This eye also has it has a glaucoma ceton. I had to move my marks a little bit because the glaucoma ceton was in place. And this is a bit challenging. There's a learning curve. I'm better, I think, at it than I was in this case. This happened to be the first one that I did, and it worked okay, but pediatric eyes are softer, and even with an AC maintainer, the eye really doesn't ever firm up, and this second haptic is a challenge. I do recommend that you use the Zeiss CT Lucia lens because the haptics are so much better at not kinking. They will take much more punishment than the three-piece Alcon lens, for instance. Now, if you're an adult cataract surgeon and you do a lot of kids, the most popular technique you're going to have is a manual posterior capsulorhexis and novitrectomy, and that's an elegant technique, and I certainly use it mostly in kids above about age 5 or 6. Below that, I really am partial to adding the vitrectomy to prevent this vitreous face being used as a scaffolding. But in the older kids, certainly a great technique. We deal with growth of the eye too, and that's a big challenge. One way we deal with predicting how long the eye will be and what implant we can put in to get near emetropia at age 20, for instance, is to use this regression formula. This has worked well for us. It predicts the axial length in any given child, individual, at age 15, age 20, whatever you want to put in. And so we use this to help us predict on an individual eye basis which implant to put in. I'm also dealing a little differently now with the challenge of parental compliance. We don't know, some parents get the drops in really well, other parents don't get the drops in, the child fights. These physician-administered medications that are now on the market give you a sustained release around the clock with a built-in taper. They release dexamethasone even when the child's asleep. And we are involved in a randomized clinical trial using both Dextenza, which goes in the lacrimal puncta, and Dexecu, which goes in intracameral into the anterior chamber. In the older kids, I'm using it every week. I'm using Dextenza pretty much every week. In the older kids, the clinical trial is only on 0 to 3, children age 0 to 3. In the older kids, I've found it to be a very nice addition that takes some of our parental compliance off the table. So with this Dextenza, I'm doing no drop cataract surgery in these older kids. I use intracameral antibiotics, and I don't use any post-op antibiotics, and I don't use any post-op drops, any steroid, unless this Dextenza proves the inadequate control inflammation. This is our early report, but now we have many more kids with this insert that have done well. So I think that's something that you should consider trying. As I said, I use intracameral antibiotics. I would not do a case without intracameral antibiotics. I've been in that camp for many years. This was nice to see a safety article saying that intracameral oxyfloxacin is as safe as putting it under the subconjunctival. But I use it in every case. And that's the end of my presentation. I want to give a shout out to Rupal Trivedi. She's my research associate and very good at analyzing data, and I couldn't do any real studies without her. Thank you for your attention.
Thank you, Ed. This was a wonderful update in the year 2022 about how pediatric cataracts can be treated. A lot of good insight tips, and we will discuss it later on after the last presentation. And I would like to introduce Chris Lloyd from the United Kingdom. He is a pediatric ophthalmologist in London, and he will talk about pediatric cataracts, the role of genetics, and I think that's something we will hear about more and more. And I'm really delighted that Chris can present this presentation, although he will not be able to take part of the discussion, which we will have exactly after this presentation. And let's hear it from Chris.
Thank you very much. My name is Chris Lloyd. I'm a consultant pediatric ophthalmologist at Great Ormond Street Hospital. I also have an academic affiliation to Manchester University as well, where I worked for many years. My remit today is to talk about pediatric and congenital cataract and the role of new diagnostic techniques in making a precise diagnosis in these children. I have no financial disclosures to disclose. So is cataract really a diagnosis? My response to this, of course, is no. And I'm going to talk today about what systemic disorders are most often associated, what pre- and post-operative tests should routinely be performed, and what is the role of genetics and genetic testing in 2022. And the bottom two images here illustrate how important and how helpful genetic testing can be. This was an infant who presented to us with quite marked ocular malformation. You can see there are bilateral uveal colobomas. There is cataract formation, shallowing of the anterior chamber with obliteration of the anterior chamber centrally, PFV, cataract, and a large stalk extending from the PFV malformation to the retina in the right eye. Now, we didn't know what that diagnosis was, but genetic testing identified mutations in the RARB, or retinoic acid receptor beta gene. This is an important transcriptional gene, which we were able to identify using modern techniques and thereby provide a precise diagnosis for the family. What's the epidemiology of congenital cataract? Well, the work that was done by my colleague, Professor Jugnu Rahi, with the British Congenital Cataract Interest Group indicated the incidence, certainly in the UK and Ireland, is around 2.5 per 10,000 by the age of 1. And this is similar to other studies that have been carried out in the developed world. The incidence is higher in the developing world because of infection, perinatal, or rather prenatal infection and environmental causes. This incidence increases by the age of 5 to around 3, and a little bit higher by the age of 15, again, relating to developmental and environmental causes. We know that around 3/4 of pediatric and congenital cataracts are non-syndromic. When I was a fellow in the 1990s, I was tasked with producing a care pathway for children presenting to our clinic with congenital cataracts, and this is what I came up with. And it sort of works, but it's a bit clumsy and clunky. So when a child presents, you examine them, take a careful history, confirm that the diagnosis is correct, examine the parents and relatives, check to see if they're dysmorphic, look for neurodevelopmental problems and systemic disease. And obviously, as an ophthalmologist, you may not be expert at that, and so you involve your pediatric colleagues. Metabolic investigations may be required, genetic testing, which certainly back in the 90s and early 2000s involved guessing what was most likely and doing individual gene testing. Karyotyping is important, looking for gene deletions or large chromosomal deletions rather. And then once that diagnosis is confirmed, carefully assess for other associated structural abnormalities and then carry out the appropriate surgery if indicated. So this is a long-winded and challenging pathway which involves lots of different services and which at the end of the day was not very effective. The diagnosis was delayed and in most cases we didn't get an answer, and we carried out a study in Manchester about 6 years ago, 7 years ago. We looked at 29 successive infants presenting with bilateral cataract, tested using the traditional testing pathway, and showed that in only one was an abnormality identified, a gene deletion, and that was not necessarily the underlying cause of the cataracts. So there must be a better way, and we have now moved on to more precise diagnostic testing, which I'll talk about. What are the systemic disorders that you want to seriously consider? Well, I've listed them here, and I'm not going to talk about all of them. I'll mention a few. These make up around 1/4 of the cases presenting to you in Western Europe. But there may be a different balance if you're working in different parts of the world. This list is not remotely comprehensive. It just mentions some of the important ones, or most of the important ones. Crystalline gene mutations account for 50% of pediatric cataracts. Crystallines are important structural proteins, some of which also have a chaperoning property. In other words, they're important for protein folding and conformation. The majority of crystalline mutations are dominant missense variants, and there are 13 crystalline genes expressed in the human lens. 12 are associated with cataract, and I've listed them there. CRY-AB is the only one expressed outside the lens, and this mutations in this gene can be associated with cardiomyopathy and myofibrillar myopathy, as in this little boy here. So it's important to make a diagnosis because these children can become very unwell, and this young boy spent a lot of time on the intensive care unit. Lowe syndrome, which is due to mutations in the X-linked gene OCLR1, predominantly affects male infants. They present with these irregular dense cataracts. They may develop glaucoma, and there are important maternal carrier lens signs, which you can see on the lower images here. Typically, they develop peripheral cortical flex, but there may be posterior subcapsular opacities as well. Renal disease and neurodevelopmental delay are the important systemic features, and these children are also prone to early onset and severe epilepsy. Oculofaciocardiodental syndrome is another X-linked dominant disorder, and it causes ocular, craniofacial, cardiac, and dental abnormalities. Again, mostly in females. It tends to be a fatal disorder in male infants. The gene which underpins it, BCOR or BCOR, encodes a repressor protein which acts on the gene BCL6. And this is really important in early ocular formation and in the formation of other organs. In females, because there are 2 X chromosomes and lionization occurs, there are very variable phenotypic changes. The cataracts may be very asymmetric or appear to be unilateral. However, most affected females have significant cataracts and a degree of microphthalmia. We know that comprehensive testing is now available across the developed world using advanced sequencing technology, and we can now screen all known cataract genes simultaneously. And I was privileged enough to be involved in the group led by Graham Black in Manchester that published the work demonstrating this. And these tests have been validated, they're sensitive, accurate, and reproducible. What's the pickup rate like? Well, when you look at how appalling the pickup rate was in the past, we're now approaching 60%. So of those that are solved, around 6% have a metabolic disorder. And this is important, and I'll come on to talk about that. 21% in the Manchester group between 2013 and 2018 had syndromic cataract. In other words, there were other problems associated with the cataract. And as previously thought, around 3/4 were non-syndromic. Of those cases that were solved, of the sporadic ones, you can see that the majority are de novo mutations in known cataract genes, but a smaller proportion were due to compound heterozygous mutations. And the genetic etiology, again, as previously thought, the majority are due to autosomal dominant genes, but also a significant number with recessive and X-linked disorders. And the isolated cataract is caused predominantly by dominant missense variants. And the mechanisms, the underlying genetic mechanisms are demonstrated in this pie chart here. There are other mechanisms, including splice altering and nonsense mutations. And I've listed here the non-syndromic genes which are associated with cataract. And obviously this is a busy slide, but it gives you an indication that most of them are dominant and that they're made up largely of crystalline and connexin mutations, but there are others which are very important. And it's interesting, now that we do genetic testing as a routine investigation, we are identifying more and more of these genes. One of the messages I want to get across is that metabolic disease is very important, and it's an important diagnosis to make because we can change children's lives. It was previously assumed to be rare and of low relevance, rarely reported and poorly described, but early diagnosis is very important because treatments are available. And here, this family demonstrates why this is so important. These are three young men who presented early in childhood with cataracts and mild learning difficulties. They were found to have a mutation in the gene, homozygous mutations in the gene CYP27A1. This codes for a condition known as cerebrotendinous xanthomatosis. This is a condition where there is abnormal fatty acid metabolism, and it's treatable. You can treat it with chain-O-deoxycholic acid and statins. If you don't treat it early, these individuals suffer from premature atherosclerosis, peripheral neuropathy, and neuropsychiatric problems, and they often die from heart disease in their 30s and 40s. They also develop tendon xanthomas, which are less serious, but which is what gives the condition its name. If this diagnosis is made early, the life course of these children is altered forever, assuming they get the appropriate treatment. So this is the diagnostic pipeline which we now use routinely. When a cataract or lens abnormality is identified, a sample is taken, and we now take a sample from both parents as well. So we do trio testing. The sample is prepared and sequenced, bioinformatics are carried out, analysis and variant interpretation is performed, and then there is a multidisciplinary team meeting, including the lab-based technicians, the geneticists, and the ophthalmologists, and the genetic counselors. A clinical decision is made, a report issued, and the result is delivered to the family. And appropriate treatment is then, and long-term management is put in place. However, we don't get it right always, and there is a non-diagnostic rate, and this relates to the fact that we don't know all of the genes yet, and also that the sequencing techniques are not absolutely perfect. So more work is needed. But I would emphasize that modern genomics has transformed our way of approaching children with cataract, and cataract is not a diagnosis. Thank you very much.
Thank you, Chris. This was a very wise lesson for us in 2022. And looking back at my own career, I think I missed a lot of these genetic etiologies. I hope my successors, the young generation, will do better with people like you, Chris, who will go to the bottom of the cause of these metabolic or genetic causes of pediatric cataract. I think we are now able to answer questions. Darius?
Yep.
Yep.
I'll start with the LHON presentation by Claudia. There was no specific question, but I wanted to ask Claudia. My understanding is that a lot of children actually are carriers for the mutation, but not all of them ever develop LHON. Can you explain that, or is there any thought, why that is? And in turn, if one understood that mechanism, could that be used as a therapy or as a prevention?
Yes, this is actually a big issue, and it's not known who develops LON or who converts or not. And to this date, there are no predictive factors, because if there was one, we would like to treat prophylactically. and which would make more sense than treat when already tissue is destroyed. But also in adults, I think only 40% convert to LON, and all the rest are asymptomatic carriers. So we have a follow-up of huge families of asymptomatic carriers, and as far as I know, since we follow them, none of them converted to the disease, so they only come by chance.
Thank you.
Claudia, I also have a question for you. How do you discover them? And if you discover them, how quick can you treat them? And for how long you have to treat them?
So the discovery is often, usually most patients are suspected optic neuritis in the beginning, and I would say 80% get intravenous corticosteroid, and MS is excluded and all the screening is done. And then when they don't become better and the second eye gets involved, usually the diagnosis LON is established. So it's the same thing still, because also OCT and VEP don't really help to distinguish. It's the same in adults as in children, and in children, we further have the issue that the onset can be insidious or only one eye involved, as I said before. So we only have to remember that this can happen in children. That's the one thing. What was your second question? Sorry.
How long do you have to treat?
To treat? We treat them for 24 months until a plateau is reached. And if we have the impression that they're still improving, we continue. So in the children, we saw, interestingly, that it's in the third year when we saw the most improvement. But it's a very small group only, and yeah, certainly we need more data and more patients.
Yeah.
Yes.
Well, luckily it's a small group, because you never wish a disease like this to young patients, yes, or any patient. But thank you for your excellent presentation.
You're welcome.
We learned a lot, but we still have to work
yes,
on this issue. And good luck with your meeting in Munich.
Thank you.
Then I would like to go to Anne Hellstrom. Darius, were there questions from the audience?
Yeah, I don't think there was a specific question I could see in the from the audience, but I had two questions for Anne. First of all, fantastic.
Yes, well.
Yeah, amazing work. I mean, it's just really beautiful, absolutely beautiful. One question was, you mentioned you mentioned omega-3 and omega-6 supplementation, and that it can work. In cancer, they use omega-3 as an anti-angiogenesis agent and as an anti-inflammatory agent. It affects the prostaglandin pathway in a way that it's anti-inflammatory. Yeah. Is that how you think it works in ROP, anti-angiogenesis and anti-inflammation? Is there an inflammatory process in ROP?
Yeah, that's a very, very good question, and it's actually a very up-to-date question regarding pathogenetic mechanisms and ROP. And in fact, we have seen that there is a close association between DHA, omega-3, and inflammatory markers in the preterm infants. So I would think that one way of its action is actually through downregulating inflammatory responses. I don't think that DHA is anti-angiogenetic itself, but it might promote other cells to be anti-angiogenetic. Regarding omega-6, we know that is pro-inflammatory in adults. However, in a growing fetus, it is extremely important for all membranes. So we have seen that a certain level of arachidonic acid is actually required for DHA to have its actions. So I think it's a bit different in adults and in these extremely preterm infants.
It may be the angiogenesis effect is described in oncology, but it may be that it is cancer specific, especially prostate disease and breast disease. The second question I had was about VEGF. I mean, you must know it if anyone knows it. Are there systemic long-term ill effects of giving a baby VEGF?
Well, I really hoped I could answer that question. The problem is that there are actually, at the moment, there are no prospective randomized trials looking at the baby's systemic, like the effects on the organ systems for long term. There was one publication from the Rainbow trial, which was the ground for Lucentis to be approved, but that was at 2 years of age and not looking at all organ systems and not looking at MRI of the brain, for instance. But what we do know is that this agent, we know that Lucentis is found in the circulation for approximately a month, maybe a little bit more, and that it suppresses the circulating VEGF levels. So theoretically, it could have an impact, but as of today, we don't have that information.
But you can detect VEGF in the bloodstream. It is not just theoretical. There is actual presence of VEGF in the bloodstream detected.
Yeah. There is presence, but it also depends on what how you measure it in serum or in plasma, and of course it's more in serum. But we know that the levels are suppressed. The VEGF levels are suppressed for approximately 4 to 6 weeks after Lucentis, and a little bit longer for Avastin, and maybe even longer for Eylea.
Thank you.
Thank you. I think we have to continue, otherwise we cannot answer all the questions. Darius, you got a lot of
I got a lot of questions.
And I was also, maybe you can pick up some of them, because most of them were on how do you apply the timolol. Yeah.
So the question that always comes up is, I say timolol drops, and people say, what about ointment or gel? And it's of course the perfect question to ask. The fact of the matter is, timolol maleate is like olive oil. It is, if you next time take a timolol bottle and just put a little bit on your finger, it is like sun cream or sun oil. It goes in straight away. It's very lipophilic. The maleate is a long carbon chain, and it makes it very, very lipophilic. So actually, even though they're called drops, they're actually very lipophilic, and they have the effects of gel and ointment, exactly as one would think. So that was one question, a set of questions. Another one was whether you could inject it directly into the hemangioma. I would not at all do that, because of course the hemangioma is vascular. If you inject it, you can get bleeding, and number two is you now inject a high dose bolus into a vascular component, and it can spread, at least theoretically, into the venous circulation, and then from there into the systemic circulation, and it may cause sudden cardiac or respiratory effects. So I would not do that, and there's no need for it. If you put the drops into the skin, it is absorbed very quickly, and you can detect it in the bloodstream.
Okay.
The third question was.
We only have 1 more minute left for the questions. Maybe you can answer other questions by email. And I would like to continue then with Ed. Ed, you have the last questions. One of the questions is the Dexacu or the Dextenza. People are asking, will that not fall out of the punctum?
Right. No, that's a good question. It goes in as a very thin a log shape, but as soon as it gets wet, it swells up like a sponge, and then it won't come out. So if you get it wet before you get it in, you'll have to discard it and get another one. So it really swells up, and we haven't seen any of them dislodge.
Excellent. We are very happy that the Silsoft lens is starting to get back on the market, because we have lots and lots of parents complaining that the alternatives are not really as good as the Silsoft lens they were used to. And so they are back on the market in the United States.
Yes.
And
yes.
So in a couple of months, we should receive them in other parts of the world.
I hope so. I mean, they're coming in a blister pack rather than a bottle these days, but we've been receiving the new packaging already.
And same fit, same substance,
same lens. Excellent. They just had problems with the packaging.
Excellent. Another thing I noticed that I use in some surgeries still using a traction suture through the superior rectus muscle.
Yeah, I still do. I know that's an old school thing, but the Bell's phenomenon really affects things when the child gets light under general anesthesia. I still find that it's useful to have that foro-silk on a taper needle under the superior rectus muscle to help control the glow. So I still use it.
Thank you. And interesting that you have getting a lot of experience with artisan aphakic IOLs in a short time. But that's compassionate use in the United States. And always for other listeners, never forget to make a peripheral iridectomy in these cases. At least that was how I was taught.
And very quickly, there was a question about intracameral steroid, and I do commonly use dexamethasone, preservative-free, 0.1 cc of the 4 milligram per cc of dexamethasone right with the antibiotic as the two separate injections right at the end of the surgery. That helps.
Okay, well, thank you very much, all presenters. These 2 hours went over very quickly. Thank you very much on behalf of the SOE and also from the European Paediatric Ophthalmology Society and the International Paediatric Ophthalmology and Strabismus Council. Thank you very much. And for people who would like to see it back, it's on the website of SOE webinars. Thank you very much and stay safe.
Bye.